Welcome everyone to this second webinar from the Junior Doctors Network of the World Medical Association set of webinars. Today's webinar named Gender Equity in Health, Leadership, Evidence, and Quality of Care. My name is Pablo Estrella Porter. I'm the chair of the Junior Doctors Network of the WMA, as well as a physician from Ecuador and a public health specialist in Spain. Together with me is also my colleague, Dr. Jesul Ponce. Jesul is a medical doctor working in emergency care within the Spanish public health system. She holds a PhD in public health from the Complutense University of Madrid and serves as the Medical Education and International Mobility Director of the Junior Doctors Network. She's also technical assistant, consultant supporting communities with UNOPS, and member of the WMA Gender Equity Task Force from the JDN. Welcome, Jesul.
Thank you
Uh,
so much, Pablo.
Together with us, we also have Dr. Elena Marvan. She is a global health scientist with an over a decade of experience in infectious disease, NCDs, and maternal and child health across multiple regions. She holds a PhD in transnational medicine, University of Barcelona in ES Global, and works at FIND, at the Barcelona Institute of Global Health on Implementation Science. She is an associate professor at the University of Balearic Islands. She was a co-founder and is currently the president of Women in Global Health Spain. Welcome, Elena. And finally, but not least, we have Dr. Lujane Aldolmani, sorry. She's leader in international health environmental policy with a demonstrated history of working in the medical practice. Strong global health professional and gender champion with Doctor of Medicine from Kuwait University and Masters in International Healthcare Management, Economics and Policy from Bocconi University. Professional Networks Lead of Healthcare Without Harm and past president of the WMA in 2023-24, and currently the chair of the WMA Gender Equality Working Group. Welcome, Lujane. So without any further ado, I would like to give the floor to my colleague, Dr. Jesul Ponce, to also give some words of introduction to this webinar.
Thank you so much, Pablo. Okay, before we begin, I would like to extend our best wishes to Dr. Ana Quest, who unfortunately could not join us today due to personal reasons, but we hope we will continue discussion with her in the future for the other activities. Okay, to briefly frame today's conversation, I would like to highlight an important invention that connects leadership, research, and clinical practice. As Pablo mentioned it, I'm a medical doctor too, so gender equity in health is not only a matter of representation of rights, it's also closely linked of the quality of care and clinical decisions making. It's importantly mentioned that men and women health should not be understood as a different or completely separate game. Addressing gender-related health challenges benefit everyone and contribute to stronger and more effective health systems. So we know the gaps in sex and gender disregarded evidence continue to exist across many areas of medicine. These gaps can influence how diseases are recognized, studied, and treated, and may ultimately affect patients' outcomes. At the same time, patterns and health outcomes often reflect how gender norms operate in practice. For example, we can see the higher rates of alcohol and substance use, as well as lower control of these conditions, such as hypertension among men, have been linked to lower engagement with health service. In contrast, to other conditions such as eating disorders are more prevalent among women, particularly in young women. So this difference highlight the need to better integrate sex gender consideration into research, clinical practice, and health system designs. So beyond research and data, these dynamics are also reflected in everyday clinical practice, research, and more. So across different settings, including well-resourced health system, it's very not uncommon to observe too the difference in how healthcare professionals are perceived, where clinical authority may be questioned or interpreted differently depending on gender. In my situation, for example, sometimes when I approach or when I have some emergencies and I am working with a man nurse, many people approach him and just ignore me just because they thought that he's the doctor, me the nurse. But anyway, at the end, we are a team. But it's important to mention this kind of structural and important gender situation and disparities. So yes, this reflects broader structural and cultural patterns within the health systems. Yes, this calls for a careful and balanced narrative, one that recognizes how gender norms affect health differently, while reinforcing that improving outcomes for group contributes to better outcomes for all, not only for patients, but only for the people who are working into the patient, researchers, or even people who is leadership, the policies or policymakers. So this is the perspective is central today discussions, and it's connect gender equity not only leadership and governance but also research, clinical evidence, and the quality of care we can provide. So I really would like to invite our speakers to share their perspectives. So Pablo, please, could you moderate this or me?
Of course, yes, I can
Thank you
take
so
over.
much.
Thank you, Jesus, that I know that you're also in the middle of a shift. So now is now my pleasure to give the floor to Dr. Elena Marvan Castro, who will help us also explore how gaps in integrating sex and gender into research affect clinical evidence, guideline development, and patient care. Elena, the floor is all yours, and we can see your screen.
Okay, thank you very much. Let me move this so you don't need to see it. Yeah, okay. Sorry, I need to reshare my screen again. Okay. All right. Well, first of all, thank you so much for the invitation. It's my pleasure to be here with you today. And I'm going to be talking about the movement of women in global health and especially about our chapter. But first, I would like to make an introduction to put in context why we are talking about gender equality and equity. So, as Pablo already mentioned, I'll just highlight here very briefly some of the hats that I wear. So, apart from being the co-founder and president of Women in Global Health Spain, I'm an implementation scientist working at FIND and at the Barcelona Institute for Global Health. And within that research, my main focus is to work on innovative diagnostic tools, especially in low and middle income countries, non-invasive tools or tools using AI to optimize diagnostics for different diseases, including, for example, neglected tropical diseases. And I'm also an associate professor in nursing studies in global health at the University of Balearic Islands, as it was mentioned earlier. So we know that most of the healthcare professionals, like 70% of them, are women. And this is, if you see this graph, this is not the same case in leadership positions. So we know that mostly 75% of men are the ones deciding everything regarding to health. So they are in leadership positions in health. So we can say that we have like a feminized global health workforce, but without power or without being incorporated into these power structures. And this reflects an imbalance. Here we can see some of the numbers. For example, women members as the percentage of the WHO Executive Board. We have from 2020 to 2023, how this has been between 32, 18, 9, 6, 15, or 21%. So we are not close to having a 50% of women representation as members in this executive board. But we also have another example with member state delegations to the World Health Assembly that are by women. So we see the percentages are very similar from 22% to 32%, not close to this 50% that it should be incorporated. And when we see these numbers, one could say, okay, it takes time for women to get there. But it's not only a matter of justice, it's also a matter of policies and actions that are taken. So one very specific example about the implications or the conclusions about not having women leaders in health is example of the personal protective equipment during the COVID-19 pandemic. So this was a study made by Women in Global Health, and it was mentioned that the PPEs, they were designed for a reference men, Caucasian, from 20 to 30 years of age, 170 centimeters tall, of approximately 70 kilograms. So this that is designed in paper by those who are taking the decisions, generally men, this is not making the reality of most of the healthcare workers and especially the frontline healthcare workers that we saw in the COVID pandemic, as in many other times. That are most of them women from different places, years, kilograms, etc. So he does not represent everyone. And this is the example that we should take into account. This PPE was designed for them. So, for example, it increased the being uncomfortable wearing it, and also some urinary tract infections by women who had to wear it, and it was not comfortable to have it for long hours. So we know that women contribute to the healthcare system by different means. So we are the majority of the social care, the ones providing the most of the health services, essential frontline health workers. We saw it with the pandemic, but also with other pandemics, with the Ebola and many other ones. So women are at risk to their own health and their well-being. They are the majority of the community care, and they carry the burden of the domestic work. And community services also are led by women, such as local NGOs, for example. But in the contrary, they receive lower pay, insecure working conditions. They are not accounted for in these leadership roles. They have the burden of unpaid work or unrecognized work. This example about the PPE that doesn't fit them, but this is only a very specific example. This can be reflected as in many other ways. They have a lower social value for their work. They receive gender-based violence and insufficient funding for women's NGOs, and especially also like for women's health in research in general. So we know that there are differences in terms of sex and gender, and this might be very simple or very basic, but trust me, you don't know how many times this is confused, even within research settings. So sex is the biological characteristics by chromosomes, reproductive organs, genitalia, and hormones that include female, male, and others. And this has a repercussion in health. Like, for example, we know that, and only very recently we have learned that a stroke, for example, is presented differently in females versus males. But if we don't study these differences, it would be impossible for us to attend and to see which are the different characteristics. Versus gender, that this defines women, men, and other, is this gender culturally defined characteristics such as roles, responsibilities, attributes, and stereotypes and norms in society. These can differ based on the different societies that we could have, but this also explains some of the differences that we can see in health, in outcomes, risk, health-seeking behavior, and others. For example, just to put an example about the neglected tropical diseases, we can see that, for example, boys that might be more prone to be playing with water, they might be more prone to having some parasitic infections that are transmitted through soil or water, versus women or girls that are having these care responsibility roles are usually infected, for example, with infections related to newborns or children, because they usually take care of the little ones in the families. And this is just an example. We can also talk about mental health. So there is, one could see that there is a higher problems of or mental health conditions diagnosed in women compared to men. But we need to analyze if this is based on a sex characteristic or this is based on gender. There might be some hormones affecting, or maybe this is gender also playing a role here, and we are overdiagnosing mental health conditions in women. So that's why it's very important to differentiate and to always put this lens into our research. what I find sometimes difficult is when we are working in global health in different contexts, is to ask for this within a survey or an interview, because many times this information is a little bit sensitive, and sometimes researchers just instead of asking about the sex and gender, they just assume based on the appearance or based on the gender characteristics a participant's gender, and this is not correct. But that's why I wanted to emphasize a little bit here the differences, because this is very important to understand the potential problems that we might face. So that's why it's very important to include this sex and gender lens in research to advance personalized medicine. We know that only 20% of women are included in clinical trials, and then approximately 50% of in vitro studies do not specify the sex of the cells. So if we don't have the data, we cannot draw conclusions. Then 20% of studies using animals models do not specify the sex of the animals. So again, many times we are just using the male animals or male cells without even saying that, so we cannot see if this is attributed to females. So both sex and gender influence disease risk, perceptions, presentation, treatment responses, and many other things within the healthcare system. And gender-sensitive clinical guidelines improve the diagnostics, the therapies, and the outcomes. So we need to have the data in order to provide this better quality care. So including sex and gender in research advances health equity while contributing to this personalized medicine that we would like for all. This is just an example about the influences in gender. So this is a study that we conducted from Women in Global Health Spain about the sexual harassment, sexism, and power abuse in academia and within the healthcare sector. We opened a survey for people to declare anonymously if they have suffered any gender-based violence within their professional, within academia and the healthcare sector, and we received more than 200 responses within a week. Then this is a program made by Women in Global Health to report the findings of the Health 2 initiative, where they concluded that trainees, interns, migrant women, women of marginalized races and ethnicities are at higher risk of sexual abuse and harassment in health due to these unequal power dynamics. So this is very important because we are not only talking about women, we are talking about all the intersectionality, all the other dynamics that are influenced by power. So this is the diagnosis that we have so far. We have lack of gender and sex disaggregated data. We have some barriers, discrimination, and biases affecting research, lack of feminist and intersectional perspectives, research on women's health conditions scarce, lack of investment, invisibilization. There is a problem with leadership gap that is also included in this wage gap, and lack of training opportunities and mentorship. So because of all of this, it's why this movement of Women in Global Health was created. It was founded in 2015 by some women professionals in global health trying to advocate for this gender equality and equity. Right now, it's been followed in more than 90 countries. There are 60 official sections with more than 70K supporters. And we also have these problems in Spain, and that's why 5 years ago we launched the Spanish chapter. And our mission is to contribute to gender justice and equality across all areas of health. We have a feminist, fair, and equitable vision of global health, and we have some values such as feminism, diversity, interculturality, solidarity, among others. Here you can see some of the events that we have done, and I really recommend that you go through our website and our social media. And this is just some information to follow us. And thank you so much. I'll be responding to some questions at the end. Thank you.
Thank you so much, Elena, for bringing the data and not just about the gaps, but also already solutions that are being put in place with Women in Global Health, the chapter in Spain. But now, before we also open the panel and section for questions for Dr. Elena Marban, we'll go with our next speaker, Dr. Lujane Alcotmani. who will bring the governance and professional leadership perspective, focusing on institutional barriers and practical reforms needed to improve representation and decision-making within medical organizations and leadership structures. Lujane, the floor is yours.
Thank you, Pablo, and hello, everyone. Just building on what Elena has already highlighted, I would like to highlight this fundamental paradox. Indeed, women make up around 70% of global health and care workforce, yet they only hold about 25% of the senior leadership positions. So, in other words, women deliver the majority of care, but remain significantly underrepresented in decision-making spaces. And we can see this imbalance clearly and visibly within the professional medical organizations. Even with our own institution, the World Medical Association, we must acknowledge that progress has been uneven. I'm very glad that we're seeing more women in leadership roles. However, governance structures remain largely male-dominated. For example, the WMA has only had one woman serve as a chair of council. All of the current members of the executive council of the WMA with voting power are currently men. Only 4 out of 33 council members are women. And just these figures clearly illustrate how deeply enriched the gender gap remains within leadership and decision-making structures. And this is not only unique to our organization, it reflects a broader dynamic systemic issue across national medical associations and professional bodies globally. I think we agree that these disparities are not due to lack of qualified women, but rather to institutional barriers embedded within the governance systems. Leadership pathways are often opaque, relying on informal networks, nomination processes that tend to favor those already within existing power structures. There's the persistence of what we called old boys club dynamics continue to shape access to leadership opportunities and decision-making influence. Now, these institutional barriers are reinforced by broader societal dynamic. I stumbled upon a very interesting report by the OECD. The evidence from that report shows that in the OECD and EU countries, girls are less likely than boys to aspire to leadership roles from an early age. Among 15-year-old boys are about twice as likely as girls to expect to work as managers, senior officials, or executives by the age of 30. Now, these differences are not innate. They are shaped by gendered socialization processes that begin in childhood and reinforced by families, education systems, media, and cultural norms. I was reminded of this recently, very personally. As a parent, I was shopping for a book for my 3-year-old. I came across a children's book that portrayed mothers as emotional and unable to control their tears, while fathers were depicted as rational and better equipped to handle crises as the leader of the family. This was just a simple example, but it reflects how early and subtly these narratives take root and how they ultimately influence confidence, ambition, and perceived suitability for leadership. Now, in professional settings, these dynamics translate into what we call structural constraints, such as motherhood penalty, limited access to mentorship and sponsorship, unequal recognition of women's contributions. Organizational cultures may undervalue leadership styles that do not conform to traditional norms, where sometimes women in leadership roles are called loud and bossy, while experiences of discrimination and harassment remain persistent barriers. Now, addressing these challenges require deliberate and systemic governance reforms. First, medical organizations must make leadership processes more transparent, more accountable. This includes establishing clear criteria for leadership roles, ensuring open and competitive selection processes, and requiring gender balanced shortlists for all elections and appointments. Second, institutions should adopt measurable and time-bound targets for gender representation across boards, councils, executive bodies. These targets should be accompanied by regular public reporting of gender disaggregated data, because without measurement accountability, progress is unlikely to be sustained. Third, governance structures themselves need to be redesigned to enable inclusion. We need to introduce term limits, leadership rotation to help prevent concentration of power and create space for new and diverse leaders. It is equally important to review where decision-making authority sits and ensure that that voting power is not concentrated within homogeneous groups. Fourth, strengthening the leadership pipeline is essential. Medical organizations should institutionalize mentorship and sponsorship programs, invest in leadership development, and actively support early and mid-career women progress into senior roles. These efforts must be adequately resourced and embedded within long-term strategies. Fifth, organizational culture must evolve alongside structural reforms. Medical institutions must actively address discrimination, harassment, and recognize and value diverse contributions, including often invisible work such as mentoring, and foster inclusive leadership norms. Gender equity cannot rely on individual champions. It must be institutionalized. Now, practical enablers are also critical. We need to have governance processes should be designed to facilitate participation, including flexible meeting formats, hybrid engagement, and family-friendly policies. These measures directly influence who's able to engage in leadership and decision-making. Finally, representation must extend beyond just internal governance. And this is what I've been focusing on because of your question, Pablo, but it has to go beyond that. Medical organizations should ensure gender-balanced delegations to international forums and actively promote women as leaders, external presenters, and spokespersons. We need to ensure that visibility in these spaces is key in shifting norms and influencing policies. Encouragingly, there has been ongoing efforts to advance this agenda. The World Medical Association is a proud partner of an initiative called Gender Equal Health and Care Workforce Initiatives that is led by partners including the World Health Organization that aim to drive visibility, accountability, and action. We have also developed policy positions for increased representation of women in leadership, stronger mentorship systems, and more equitable organizational culture. However, the real test lies in implementation. Gender equity in medical leadership is not only a matter of fairness, it's a fundamental to effective governance, stronger institutions, and more responsive health systems. So by addressing these barriers and embedding practical reform, medical organization can ensure that leadership truly reflects the workforce they represent and the population they serve. I'll stop there and happy to answer any follow-up questions.
Thank you so much, Lu Jane. So what we have heard already shows this clearly the relation between leadership, evidence, and of course that we cannot separate these issues. Governance also influence on the research priorities, on the research, and the research also shapes the guidelines and also the standards, and at the end also this has some effect on the patient's outcomes. So with this in mind, we can move now to a moderated panel discussion where we will also hear a bit more on these first takes that we had from our guest speakers. So Jisul, if you want to take the floor.
Yes, thank you so much. I would like to start first with Dr. Elena Marban. Thank you so much for amazing presentation. Even I would like to add that also is very important. We can see in research that, for example, in tuberculosis, global data shows that men have a higher reported burden of disease. However, women often they have a specific barriers in accessing to screening and diagnostic service, particularly in high prevalence settings. So my question is, how do current research practice risk reproducing gender bias in evidence generation, and what changes are most needed in research design and priority setting? Thank you.
Okay, thank you so much. Yeah, I mean, you gave an excellent example. So the thing here is that for every disease or every condition, we know that there are or there might be sex and gender differences. The thing is that if we do not study them, we cannot know. And everything that is related to gender, what I like to say is that this can be shaped or changed, even though behavior takes times in society to be changed things, but everything that is related to gender, we can affect this to, for example, the caring roles and responsibilities. Like somehow we can work on it for men, women, and different genders, be taking care of children and the elderly and so on. But we need to know if these differences that we're seeing in every condition are related to sex or gender. And from all my experience, I think that many times this is used interchange like sex and gender. So if we don't understand or if we don't have the evidence, it would be very difficult to act on it. Then the other thing that I wanted to say is that many times, or in many projects, now we need to report on these sex and gender aspects, but sometimes it's just like a checklist for researchers to say, yes, we are including women or something like this, and it's very superficial. So we really need to integrate this lens to everything that we do, from the very conception of a study design until the end, data analysis and interpretation, like throughout all the phases. This should not just be a checklist. And this should be included in formal education at all healthcare levels, like in nursing, medical doctors degrees. Gender should be a key aspect, not only for the people, for example, that are more willing because somehow they like this topic, that they, for example, might be joining this webinar, but this should be formally introduced in all the medical or healthcare careers. Then something as well that I wanted to mention is that many times when we talk about gender or women, sometimes we focus on reproductive health or women during pregnancy and childbearing. And this is just a small portion of everything that is related to women's health. But yeah, I don't know. I have many, many points to discuss, but maybe if you can continue the conversation with Dr. Lujain, and maybe I can add something later. Thank you.
Yes, totally. Thank you so much, Dr. Elena. And now coming back to Dr. Lujain, it's true that you've already showcased the example in the World Medical Association, and I'm sure that many of our listeners today live or after in the recording, they're already in somehow any leadership position, either in their junior doctors or with their local national medical associations or with other youth-led organizations, or we have also stakeholders that are not necessarily youth. But I would like to dig a bit deeper on what institutional and governance reforms you think are most needed within a medical leadership, for example, or professional organization, especially to strengthen this gender equity in representation and also the decision making.
Yeah, thanks, Pablo. I mentioned some of the actions that we need for reform, but I'm happy to dig deeper into those. And just to underline that those reforms must directly address how power is structured, accessed, and exercised. We need to ensure that governance processes must become more transparent and rules-based. As I said before, leadership selection in many medical organizations still relies heavily on informal networks and opaque nominations system. And this tend to reproduce existing hierarchies. So we need to have a clear eligibility criteria, open and transparent calls for leadership positions, and mandatory gender balanced shortlists for all elections and appointment. So this would significantly reduce those structural biases. Second, we need to ensure that those institutions move from just aspiration for gender equality to more to accountability. So when they adopt those gender parity target or report on gender desegregated data, we need to ensure that there is some sort of systematically reporting of such data, measurable benchmarks, public accountability, because without these, progress, unfortunately, will remain slow and uneven. The decision-making structures themselves must be rebalanced. In many organizations, voting power and influence are concentrated in small, often homogeneous groups. So reforms such as term limits, leadership rotations, expanding the diversity of the decision-making bodies are essential to democratize governance and really create more space for inclusive representation. Fourth, the leadership development. Even though women are well represented in the workforce, they're not really supported into transition into leadership. So when we talk about programs such as mentorship and sponsorship and even leadership development, those programs needs to be institutionalized rather than relying on ad hoc initiatives. And must be backed by dedicated resources, funding, political will, and embedded within long-term strategies. Also, the issue of the organizational culture. So the issues such as the old boys club dynamic and the gender biased leadership perception, the discrimination, the harassment, continue to undermine women participation. So in order to address this, it's not enough just to have a policies or procedures in place. We need to enforce what we call zero tolerance policies and really recognize the different or diverse leadership styles and not to be afraid of a new leader who can shake the table every once in a while and ensure that contributions are equitably valued. The practical barriers, of course, must be removed. The governance systems should enable rather than constrain engagement. I mentioned before the adoption of flexible and hybrid meeting formats and also ensuring family-friendly policies and family-friendly meeting structures and really creating the conditions where individuals with different life circumstances can still fully participate in leadership, but not just in discussions, but also in decision making. The external engagement is quite important. It's not enough that we have more women as leaders in governance structures, but also externally represented and valued as spokespersons and leaders to really shift the perception and the influence. The most effective reforms are those that simultaneously reshape governance structures, embed accountability, transform institutional culture. Only by addressing those dimensions together can medical organizations really move toward equitable and representative leadership.
Thank you so much, Lujane, and probably just to loop in both topics that both of our speakers have shared. Making changes is also up to us to advocate for. We see that either if it's on the research and evidence field, on the training, or even in the organizational structure. And probably just as a side note also to share with our participants is that the task force on gender equity from the Junior Doctors Network actually was born because of this reason. We realized that over the years we have improved quite a lot. We had women as a chair of the Junior Doctors Network, on other deputy chair positions. But of course, we see that, for example, this year the balance was not right. So we wanted to investigate a bit more of what are the reasons, and Lujane have already identified quite some barriers. But it's true that in the different organizations that we work at, we should try to see how we can implement these changes, especially in a structural way. So it's not just really dependent on who is the leadership, but actually can be part of the organization. We will open also the floor with our participants if they have any specific question or comment they would like to share. I know we have also some members of the gender equity task force here present if they would like also to share any thoughts up to now, or if you, Elena, or Lujane would like also to share, or Jesul, you want to share some thoughts until our participants also share some questions.
Yeah, maybe if I can add something. So, I mean, I think when we're talking about leadership, we know that we are half of the population, women, right? So at least just for justice and balance, we need 50% of women in leadership positions and everything. But not all women are feminists, equal to not all men are just the opposite, right? So we need this 50% of women for sure. And apart from that, we need all genders, all leaders to be having this gender lens and feminist approach. So we need both. That's why I don't know, I just wanted to mention that. And also one of the things that we can do all in our day-to-day life, for example, every time we are attending a conference, if we see an all-male panel, is not to participate on that. Like, for example, for you, like, or for men, if you're invited to a panel and you only see men, it's like, for example, you can opt to not to go and say, please invite a woman to represent in this panel. I don't know, there are so many things that we can do. And especially, I think something that I wanted to say is that we are seeing this regression in politics due to the geopolitical context that we are living now, that it's much more important to be talking about inclusivity and intersectional feminism.
Thank you, Elena. I think what you're sharing is it's super important as practical steps, and probably on a personal note, sometimes I felt like that this discussion I was not like capable or I should not be participating, but letting others participate. But definitely over the years, I've seen also with my colleagues encourage our other male colleagues to be on these discussions, and more I'm more aware of this. So I think probably that's also another part of the to-do, finding these allies, not necessarily just in one specific sector, but make it inclusive in that sense. Okay, I think there's a comment on the chat. Okay, also including the transgender and diverse individuals as well as part of the discussion, of course. Not sure if any of our participants, or I saw Shiv also present, but I'm not sure if he's able to unmute himself, as he also support organizing the previous session of the webinars.
Hi, thanks, Pablo, and thanks, Alina, Jane, for wonderful presentations. Um, uh, uh, as a matter of fact, we have done an all-women webinar on 8th March, more than 7 of them part of the panel. And we actually explored these perspectives around how women are shaping the healthcare in terms of entrepreneurship in the era of digital health, and it was well received as well. I was just thinking on this. I particularly feel that, and I echo with Pablo that we as men might sometimes feel uncomfortable being part of these panels. We think that should we like allow more space for women to do it, and just but I think the important area is about finding allies, which I completely echo. And one area that I feel more work needs to be done is about so yes, when we look at the data, and there is this gross disparity that we are seeing. I also want to understand what could be those opportunities, or I would say, what could be those mechanisms by which we can, one, promote women to take up more leadership roles. So there could be two angles to this. One, women taking up leadership roles but not feeling supported. That is one. And second, how to encourage more women to take up leadership roles, both of them. So what do you think is a greater challenge at this point of time? and how should.
Thank you, Shiv. So I'm not sure if Dr. Elena or Dr. Lujan, you want to take first this comment?
Yeah, I think we missed the last part of his question. But Shiv, please don't be shy in being part of those panels and discussions, because this is not a women-only issue. But we hope to have many women leaders as well as male supporters as part of this. And we all are part of the solution, and everyone is invited to the table. So what I've mentioned earlier really represent the barriers as well as the issues that we're currently facing of why there's less women in leadership roles. And it's not because of we don't have any suitable women or not qualified women for leadership, but we really need to create the space for that. As part of structures such as the WMA or JDN and within your own organization at a national level, creating, for example, mentorship or leadership development program would be essential, as well as leadership rotations. Really make sure that you use past leaders as well. So if you had women who've been past leaders, even men, that are ready and available to be mentors, to share their leadership experiences with the ones who are willing or might consider running for the same leadership role would be quite essential. We as physicians, we're very busy. I must say, whether we're dealing with patients or the issues within the healthcare organization and structure, and as well as personal life, especially if you're having a family. So sometimes being in the leadership position might not be as encouraging, not for all of us, depending on your aspiration and ambition level. So creating that space and balance would also be something to add to that list.
Thank you, Lujan. Elena?
Yeah, so maybe just to add is that, I mean, as the problem is very complex, the solutions also need to be addressed in different ways. So we have structural problems, like for example, most of these hierarchical structures were designed by men for men, and maybe I could say cis men. So that's why many times it's very difficult, like to engage in these positions. For example, if it requires a lot of travel, and based on these stereotypes and caring roles for women, if you are within your reproductive years and you need to be the one being at home, so sometimes you just stop doing that or stop growing into your professional career because of your family responsibilities. That should not be the case, but it is the case many times. Then we also have some other gender roles affecting women, that we suffer much more from this imposter syndrome, that we might not feel qualified for giving a talk, being interviewed on the social media, or so men are more prone to advance in these positions, even at work, for going to ask to their boss if they would like to have an increase in their salaries, for example. So there are many things related to gender. So it's not that we are not capable or that we don't have enough women that could be in these leadership roles, but the system is not created for us. And also who's taking the decisions, many of these times is like boards by men. So they are the ones deciding. And this is very similar, for example, in research. Something that I wanted to say is about research priorities. So research priorities are defined by the funders, right? So many times conditions affecting women, such as endometriosis, as many others, are not the main focus for the funders. So then they do not invest in them, and that's the problems that we're having.
Thank you so much, Elena. Shiv, I see your hand up.
Yeah, thanks, Lujan and Elena, for sharing your perspective around this. Pablo, I was thinking that during the last webinar, we also had a pledge that was taken around how do we advocate for gender equity in healthcare, and I think it would help if we can also have inputs from Lujane and Alina on those points that we had in the pledge, as we also mentioned that it was something that will be evolving during the year. I mean, just wanted to mention it here for discussion. Thanks.
Thank you, Shiv. And actually, something we have discussed. Unfortunately, Dr. Anna is not here, but we wanted also that this set of webinars is not just a space for networking and sharing these insights, but actually is the start of something more, especially on the junior doctors network. So this pledge was something that was started on the last webinar. Not sure, Shiv, if you have it at hand, and probably we can just briefly show the main points on these last minutes we have to probably provide also some insights.
Yes, absolutely, Ship. If you can share with us,
Sure.
and
Yes.
yeah, it would be amazing. And also, I just would like to comment that it's very important for sure getting involved more men in these discussions because we need to continue raise awareness in the men because it was quite complicated to have a speaker man in this webinar event. And it's something that I really particularly want to share because I have been asking and many men looks like afraid a little bit that talk about gender equity. They were like, oh, gender equity, feminism. Also, I can mention the transgender people. I can mention the LGBT plus. That for sure in the next webinar series, it would be very good to include this topic as a doctors that we are because we still continue seeing even in the clinical practice the very wrong way to approach the patient in the transgender patients or LGBTQ people. So it will be very nice to talk about in the next webinars. So thank you, Shiv.
Yes, thank you, Shiv. Probably I can take over so I can probably share it on a bigger screen that I just found it as well. Thank you. 1 second. Yes, here we go. Shiv, I think I see your mic on, so if you want to walk us through really briefly.
Yeah, sure. Okay, so we basically had three commitments as part of this pledge, and then we evolved with two more during the panel. So I think we'll just go through those. The first one was to commit to inclusive leadership, and we wanted to focus more on ensuring that women were represented, supported, and heard in decision-making spaces across the clinical practice, research, policy, as well as global health. The second area was around mentorship and sponsorship. So this is actually coming from the last question that I also had, that what could be those mechanisms where we can uplift the next generation of women in medicine, creating pathways where young women clinicians can grow with confidence, opportunity, and visibility. Um, then there was a commitment on systemic change. As was also discussed today, there are lots of structural issues which also persist. And the idea was to commit to advocating for policies as well as institutional cultures that eliminate gender bias, promote equity in leadership and research opportunities, and recognize the full contributions of women in healthcare. And then we had two more commitments that were evolved during the panel that we had on 8th March, which was around equitable access to professional development, so that women have an equitable access to professional development opportunities in healthcare. And the last one was around improving policies and practice. So putting in place policies where non-existent, and where there are policies existing, then we focused on the implementation of those policies. So what we understand is that this pledge is the overall direction where we want to go at this point. And we, I think, still need to look at those operational mechanisms by which we can make this pledge actually alive and in action. So any comments on those fronts would be really great to have.
I'm happy to jump in. Thanks for sharing. I mean, this is great. It's great to have clear pledge with a very sharp and concise points. For me, what is missing is there is nothing around addressing the harassments.
Mhm.
So perhaps zero tolerance policies against sexual harassments. Well, to be honest, for all, not just for women. But this is like really a concern and a constraint. And then the second one. I understand that the focus here is in relation to leadership, but there's a structural issue regarding the discrimination and the protection of women who work in healthcare. So Elena presented the design of the PPE. If you look at the COVID-19, in US, 75% of women who, for 70%, 75% of healthcare workers who got COVID were women, and around similar percentage in Spain. So they're rarely protected against in the issue of COVID-19 and pandemics overall, despite being the major contributor in healthcare services. So perhaps having a point on that also would be important. So just to walk the talk. And the question is, when designing such pledge, what is the accountability? Is he planning to measure or ask the ones who sign it to report on their contribution or their implementation of that pledge? Because I have been part of many pledges in the past, and it's usually just a ceremonial thing where you just sign and
Mm.
back to normal business, I guess.
Yeah. Thank you, Lujane. And I think you've just highlighted the main barrier, that is how to implement this one. So we will definitely first work on this to have it outlined, covering the points also that we're missing and what we're mentioning, and definitely see how structurally we can implement. I see that Amira has the hand raised. If you want to participate briefly, please, Amira.
Thank you so much, Pablo, and for the speakers, Lena, Jesus, and Lujane. I was clapping virtually the entire time. Thank you for having such a holistic insights. So my question is about the class inclusivity combined to gender inclusivity. Do you have any insights on how can we be more sensitive to the class disparities and social economic situations of women in leadership in general? And my second question is for the WMA team. If you can share with us briefly if there are task forces where we can join and help and participate. Thank you.
If I can jump in, I
Yes,
love this
please.
question. And that's why we were talking about intersectionality. So it's not only women. And many times the women that get to this leadership position is because they are coming from a high social class. So they already had all these opportunities that many of us just didn't, right? So yeah, I think integrating this intersectionality approach, so trying to include not only gender, but class, ethnicity, racialization, migration status, all like women living in conflict areas, do not forget about them. Like all of these issues, it's the only way to look for it. Like women, we are not equal, so we should not be talking just about women, but all these other factors and power imbalances affecting us.
Thank you, Elena. And as we're almost over time, probably just for our members that are willing also to engage in the Junior Doctors Network, we have this gender equity task force that we're also happy to open the space for members who want to participate. So, Amira, I'm not sure if you're already a JDN member, but we can contact you, or please, as you have all our emails, feel free to email me or Jesul, and we will also include you in the sessions that we have specifically on this discussion. So probably just to close up, if our speakers want to give a 1 minute closing statement so we can wrap up to this webinar. Elena, would you like to go first?
Yeah, thank you. Well, I mean, just to wrap up everything, we need women in leadership positions. We need all genders people trained in feminist, in intersectional feminism. We need funding. We need evidence for advocating and advancing in women's health conditions. And everything needs to be integrated within this sex and gender lens. So yeah, let's advocate all together to build a better world, especially in the current times that we are living right now with these regressive policies and everything that is happening in the world. Thank you so much for for being doing this.
Thank you so much, Elena. Lujane?
Yeah, my last message is to the junior doctors and junior doctors network. And I think that you are in greatly positions to lead an example. I'm not talking as future leaders, but also as current leaders in the medical organizations as well as in healthcare institutions, to really create this space for more inclusive leadership, as well as to shake the table a little bit and not to be intimidated by structural barriers and societal norms that are imposed by previous generations. It's going to be hard and not easy, but it's also about implementation as well as a strong will.
Thank you so much, Lujane. And Jesul, if you want also to give the closing of this webinar.
Thank you so much for the whole being here. I'm very happy, even working with some externals like Women in Global Health Spain in this situation. We hope to do more webinars, as we already said. We will do, and we will continue working on this also in medical education working group and the other working groups, because at the end, as Elena and Louis James already said, that this is gender. I think that it has to apply in many things. It's not only in one leadership or one topic. We need to apply the gender perspective in many other working groups into the JDN, but also working very close with the other partners and another NGO. So I'm very happy for this webinar. So thank you so much, Pablo, for moderating. Thank you so much for our to our speakers to be here, and the audience too, and the people here. Thank you so much. So, Pablo.
Yes, with this final words, I think we can close this webinar, and for sure you will see more of this task force and the JDN working to advocate on this really important topic. Thank you, everyone, and see you in the next time.
Thank you so much.